Welcome, and let's talk about women's sexual wellness and vitality. Sexual complaints are common in both men and women, and failure to have these problems diagnosed and treated effectively can lead to both personal distress and relational disruption. Sexual complaints are independent of race, color, and creed or ethnicity. Women of all races and backgrounds are at risk for and complain of sexual issues. Although much of the sexual medicine research and information readily available typically focus on the upper-middle-class Caucasian female, new data support that minority women and those of different socio-economic classes should also be asked about, assessed, and treated for sexual complaints. Sexual health and wellness is often influenced by a variety of cultural issues. According to the World Health Organization report on education and treatment in human sexuality, sexual health is the integration of the somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. Sexual health should not be a privilege of the few and well-insured. All women deserve access to well-qualified sexual health specialists. Sexual medicine is the specialty that deals with sexual health. It can be anything from sexual disorders to concerns with your body. Pain or low sexual interest are common problems too. I really didn't even know that it existed until a friend told me about it. I was suffering in silence and thought that I was alone. It's not true. You do not have to suffer alone, there is help available. Questions and answers about women's sexual wellness and vitality. Question 1. What is the incidence of sexual problems and why study them? It is estimated that 43% of all women suffer from some form of sexual problem or complaint. Low desire or hypoactive sexual desire disorders are the most common forms of sexual complaint. The National Cancer Institute estimates that 40 to 100% of female cancer survivors suffer from sexual problems that cause personal distress. Women with any chronic medical illness including hypertension, diabetes, or endocrinopathies, all suffer from sexual complaints. The data do support the fact that as women age, the incidence of sexual complaints increases. However, older women are less bothered by the problems than their younger counterparts are. Although many women have sexual issues and problems, many do not complain and many suffer in silence. Clearly, only women who are bothered or distressed by their sexual health care concerns should seek professional medical care and treatment. Some facts according to a recent survey indicates that 85% of adults would like to discuss sexual functioning with their physician, however, they do not for many reasons. 71% believe their physician would not want or have the time to deal with sexual problems. 68% of adults are concerned about embarrassing their physician. 76% thought no treatment was available for their problems. There is a need for accurate medical information concerning the diagnosis, assessment, and effective treatment of sexual complaints. Interestingly, one act of sexual intercourse burns 200 calories or is about the equivalent of 30 minutes of jogging. Sexual intercourse is an excellent aerobic activity that improves cardiovascular health and releases endogenous endorphins, brain feel-good hormones. Sexual hormones may also influence and lead to lower rates of depression, anxiety, suicide, and infections and may boost immunity, which can increase longevity. Oxytocin and DHEA, which stands for dehydroepi, androsterone, two hormones that are both released during orgasm, may prevent breast cancer cells from developing into tumors. Question 2. What are the stages of the sexual response cycle? Human sexuality is not a static concept, but one that is dynamic and multidimensional. It is a product of interpersonal, biological, psychological, and cultural mechanisms that help formulate an individual's personal view of sexuality. Each individual has a personal and unique sexual schema. It is not possible to impose a singular approach and view on sexuality that applies uniformly across races, sexes, and ages. The following is a description of the phases of human sexual response. 1. Sexual desire or interest. Sexual desire is often characterized as innate hunger or interest in pursuing sexual activity. With respect to female subjects, there is often conflicting data as to normative sexual desire. Some emerging research demonstrates that about 1/3 of women are based in sexual neutrality, which means that they are responsive to sexual cues from their partners or their environment. For example, she gets the warm fuzzies at the sight of a special bouquet or box of chocolate. Another third have a baseline of low to moderate desire on a daily basis, and this can be escalated or diminished depending on the situation or circumstances. The final third may operate more like men, with heightened sense of sexual desire and hunger for the pursuit of sexual activity. 2. Arousal. The arousal stage of the sexual response cycle is characterized by physical changes in your body. Blood pressure and heart rate become more rapid. Breasts may increase in size and nipples may become erect. The vaginal walls swell, and increased lubrication occurs. The clitoris may become swollen, and the inner 2/3 of the vagina lengthen. Arousal or excitement is often accompanied with tingling feelings or inner warmth in the genital areas. 3. Plateau. The plateau is described as the peak of sexual pleasure or plateau right before impending orgasm. Throbbing or feelings of fullness in the pelvis may occur. You may also get a flush on your face, chest, and breasts. 4. Orgasm. Orgasm is often described as an intense, pleasurable, euphoric, whole-body sensation that is achieved at the peak of sexual stimulation. Rhythmic contraction of the pelvic genital structures, vaginal, anal, and uterine muscles, occurs and an intense feeling of pleasure occurs. Some may have one orgasm and then feel satisfied and complete, whereas others enjoy repetitive multiple orgasms in a row. There are many types of orgasms, including clitoral, vaginal, and uterine orgasms. About 1/3 of women mention that they have rarely or never achieved orgasm from intercourse unless breast and/or clitoral stimulation occurs simultaneously. Some may feel uterine contractions when orgasm occurs, others enjoy the direct pressure of the cervix being stimulated. Recently, twin studies have reported that the ease of reaching orgasm may be genetically predetermined and inherited. 5. Resolution. In the resolution phase, heart rate, breathing, and body temperature return to normal or baseline. Blood flows away from the genital and vaginal areas, and you may return to the presexual state of being. Nipples and breasts return to a normal state without arousal. You may feel a sense of euphoria and fatigue. Originally, sex researchers assumed that women were linear in terms of their progression from one phase of sexual response to another. Desire leads to arousal followed by plateau, and then orgasm, and finally resolution. A novel cyclic intimacy-based model developed by prominent sexual healthcare clinician Dr. Rosemary, focuses on a more cyclic experience of female sexual response, where the cycle can be entered at any point. Women experience phases of the sexual response in an overlapping, non-sequential manner that not only incorporates physical but psychological issues as well. An important issue with this model is that sexual desire does not necessarily precede sexual stimulation or arousal. Women may enter sexual activity by being neutral, and then be motivated to enjoy and pursue sexual intimacy to enhance connectedness with their partners. Others may enjoy sex merely for sexual activity. Sexual activity creates both positive and negative feelings motivations toward subsequent episodes. Receptivity and responsive desire, desire felt after your partner has expressed interest, are key elements in the Rosemary model. Recent data also suggest that some women follow the original stepwise cascade of the progressive concept of the sexual cycle of desire to arousal to orgasm, whereas others follow the circular pattern as described by Rosemary. Women are unique, and you may ascribe to one model or the other in different circumstances. It is important to understand that sexuality is fluid and that perhaps either model suits you. Question 3. What is normal sexual behavior? Normal sexual behavior is difficult to define, because each unique individual ultimately describes his or her own level of sexual functioning. For example, many couples enjoy twice-weekly sex, others are once-a-weekers. Both may be equally satisfying. On average, most couples have sexual intercourse 2 to 3 times a week, but these numbers are definitely affected by a variety of factors such as stress, children, financial pressures, illness, and marital conflicts. Normative values of sexual function are defined by the society and culture in which you live. Some traditional cultures are sexually open and expression is permitted, whereas other cultures do not advocate an open expression of sexuality. Whether you have sex once a week, twice weekly, monthly, or once a year, you and your partner should define normal sexual intimacy as a couple. Deciding on your normative level of sexual interest and activity is an individual journey and often a challenge. Question 4. What are common sexual complaints? According to the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, there are many categories of female sexual complaints. Classification includes disorders in desire, affecting motivation to engage in sexual activity or thoughts about sexual intimacy, arousal, affecting psychological and physiologic excitation in response to sexual stimulation, orgasm, diminished, delayed, or absent peak intensity of sexual pleasure, and pain, genital or pelvic pain that occurs before, during, or after sexual activity. Hypoactive sexual desire disorder is the persistent or recurring deficient or absent sexual fantasies and desire for sexual activity that causes marked distress or interpersonal difficulty. Most commonly, women say, "My libido is low" or "My sexual desire is low." Sexual desire is often called mocho, a term that encompasses more than just sexuality and includes an overall joie de vivre as well. Female sexual arousal disorder is the persistent or recurrent inability to attain or to maintain until completion of sexual activity an adequate amount of genital lubrication or a swelling response of sexual excitement. This disorder causes interpersonal difficulty or marked distress. This disorder has many facets, including subjective arousal disorder, diminished feelings of sexual arousal, excitement, or sexual pleasure. Vaginal lubrication does occur. Genital arousal disorder, seen in women with nerve damage or estrogen deficiency, where there is minimal vulvar swelling or vaginal lubrication and reduced sexual sensation from caressing the genitals. Subjective excitement does occur, and combined arousal disorder, the most common type where both facets of arousal are affected. Female sexual orgasmic disorders are persistent or recurrent difficulty in, delay in, or absence of attaining orgasm after sufficient sexual stimulation and arousal. These too include personal distress or interpersonal difficulty. Female sexual pain syndromes include dyspareunia, vaginismus, and other pain disorders. Vaginismus is defined as the persistent or recurrent involuntary spasm of the outer third of the vagina that interferes with intercourse. Dyspareunia is a broader term that is often used to describe genital pain associated with interpersonal difficulty. Pain syndromes can be complicated and complex with respect to etiology and treatment plans. Sexual disorder may be situational, occurs in one situation, or generalized, occurs in all situations, lifelong or acquired, and may have multifactorial components in its etiology. The most common sexual complaint is one partner wants sex more than the other person. It is sometimes difficult to be on that same intimate level as your partner and have the same sexual responses and desires as your partner. Most men complain they don't have sex enough, and most women complain that their partner wants to have sex too much. They are also overlapping. After discussion, I realized that I not only had one issue, but that it affected other aspects of my sense of womanhood and sensuality. It all relates together. Question 5. What is sexual aversion disorder? Sexual aversion disorder is the active avoidance of or aversion to genital sexual contact with a partner that may cause extreme interpersonal difficulty or distress. The person may be extremely fearful about sexual activity. Psychological factors, severe stress, and need for avoidant behavior as well as past history of emotional and sexual abuse have been implicated in the origin of this disorder. Patients often implement various avoidant behaviors so that they may limit or circumvent sexual contact. Avoidant behaviors and strategies that have been linked to sexual aversion disorder include excessive traveling for both business and pleasure to avoid sexual partners, alteration of sleep patterns so that sexual activity is unlikely, neglecting personal hygiene, substance abuse, and appearing overtly involved with work commitments, social engagements, or family obligations. The person with sexual aversion disorder may partake in extreme efforts to avoid sexual contact, including self-mutilation, self-cutting, and gross distortions of bodily image. It is a serious medical and sexual problem that warrants a complex treatment plan that may include medical and psychological intervention. Question 6. What is persistent genital arousal syndrome? This is a disorder, which is characterized by persistent burning and throbbing sensations in the pelvic area with intense pressure that is unrelieved by orgasm or self-stimulation. Often women with this syndrome enjoy it, live with it, rarely complain, and have adapted to live with the situation. Sex or self-stimulation is often an attempt for release that is not associated with intimacy or pleasure. There are many possible treatment options that can help women suffering from persistent genital arousal. Sometimes nerve transmissions can be stabilized with such medications as D-valproex, Depakote, citalopram hydrobromide, Celexa, gabapentin, Neurontin, clonazepam, Klonopin, imipramine, tofranil, floxetine, Prozac, paroxetine hydrochloride, Paxil, olanzapine, Zyprexa, or even lorazepam, Ativan. Others have tried topical anesthetics, including lidocaine. Others have used ice applied to the pelvic area. Other proposed treatments include hormonal normalization, including normalizing both estrogen, testosterone, and progesterone, surgical excision of irritating lesions and tumors, or embolization of arteries if they are thought to be contributing to this distressing condition. Question 7. What is involved in sexual activity and love? Sexual functioning is a complex interplay between biology, physiology, and psychology. Veins, arteries, nerves, genitals, breasts, and nipples, as well as an array of hormones, neurotransmitters, and other physical components play important parts in the functioning of sexual activity. The pursuit of coupling has been under investigation for many years, and researchers are always coming up with a variety of answers as to why we love, from whom we seek companionship, and why we are sexual creatures. The trend now is to focus on major histocompatibility complex, MHC, a grouping of genes that controls immunity and influences tissue rejection. Women and men may be attracted genetically to those individuals who can optimize successful conception and procreation. In some recent studies, men and women responded positively to the scent of each other's MHC. Women on birth control, which places them in a state that is chemically similar to pregnancy, are unable to identify and react to their appropriate genetic partners. When we fall in love, two unique chemicals are released, norepinephrine and phenethylamine. Phenethylamine is an amphetamine-like substance that can affect mood and that helps create the wonderful feelings we enjoy when we are in love. Chocolate is also known to contain phenethylamine, which is why many believe chocolate is associated with increased feelings of love and sexual arousal. Norepinephrine can increase your blood pressure, increase your heart rate, cause palms to sweat, and is thought to help form a connection or help solidify a loving bond to our attraction. The physiology of the female sexual response includes the pelvic genital organs, vulva, clitoris, labia majora, labia minora, and the internal pelvic structures of vagina, uterus, ovaries, and fallopian tubes. The spinal and central nervous system are also major contributors, as are many areas of the brain including the hippocampus, hypothalamus, limbic system, and medial preoptic area. Many neurotransmitters and secondary modulators, neuropeptides such as serotonin, dopamine, norepinephrine, epinephrine, opioids, nitric oxide, acetylcholine, and vasoactive intestinal peptides have also been implicated in the response cycle. Some recent research focused on the restoration of serotonin balance as a key factor in female sexual wellness. Sex steroids are essential in the female genital response, and estradiol and testosterone have been clearly implicated in the normative functioning of the female sexual response cycle. The brain is also a critical area for sex and love. Studies of people's brains who are in love show activity in the ventral tegmental area of the midbrain, Another important area is the nucleus accumbens in the forebrain. Dopamine, serotonin, and oxytocin, which are neurohormones and neuromodulators in the brain, may also influence love, desire, and connectedness. Some new medications in development are centrally acting and act as modulators of serotonin that can create or restore a balance of hormones, thus facilitating a return of sexual desire. Often female sexuality is viewed as an interplay between brain and body. Question 8. What is the benefit of coupling? Countless research data show a survival benefit for being coupled or married. In a recent study, never married people were 58% likelier to die in an 8-year period than their married counterparts. Marriage often signals changes, decreased night clubbing, decreased alcohol consumption, and balanced meals. A Centers for Disease Control and Prevention, CDC, report in 2004 states that married people are less likely to smoke or drink alcohol than single or divorced people are. These changes in lifestyle habits may translate into less cardiovascular disease, cancer, and respiratory problems. Married people also have lowered rates of mental illness, sexual transmitted diseases, and suicide. Marriage may help spouses cope with stress. What are some erotic or erogenous zones? Sexual intimacy not only involves the genitals but other areas of increased sensitivity and sensuality, including the neck, mouth, nipples, underarms, thighs, buttocks, and even the toes. Most women believe that the whole body can be erotic and erogenous. Most healthcare providers in the field of sexual medicine will encourage you and your partner to explore your whole bodies and get accustomed to what feels good for you. Sexual erogenous zones are unique to individuals. Coupling has many physical and sexual benefits for most people. We are raised to believe from the beginning that you are to be married and have a lifelong partner. When I was a little girl, I wanted the big white wedding and white picket fence and a dog named Spot. It is almost ingrained in us that we need to pick a partner to share our lives with. Sharing your life with a partner and sharing intimacy as a couple, I think, is beneficial to both your health and your psychological well-being. I know relationships go through good and bad times, and overall it does take lots of hard work, but the benefits are worth it. Question 9. What is a post-sex headache? Headaches after sexual activity are often seen as normal, and many men and women suffer from postcoital, after-sex, headaches. Most sexual healthcare professionals are not certain of the cause, but increased blood pressure combined with muscle tension in the head and neck region all may play a role. The headaches can be mild, moderate, or severe and might last from a few minutes to several hours. If you suffer from these types of headaches, see a doctor to ensure that it is nothing more serious going on. Some healthcare providers suggest over-the-counter medications such as anti-inflammatory pain medications prior to sexual activity. Another suggestion is at the first signal of head discomfort, try to change sexual positions, which may influence blood pressure and eliminate some of the muscle tension. Question 10. How does diabetes affect my sex life? Diabetes, or sugar imbalance, can affect the sexual function of both men and women. People with diabetes tend to have problems with sexual function earlier in life than people who do not have the disease. How much diabetes affects sexual function may depend on how severe the disease is and how old you are when the disease began. In general, men and women with diabetes are more likely to have episodes of decreased interest in sex. This is especially common when the diabetes is not under good control. Sexual changes are often more subtle in women with diabetes. Diabetes can lead to changes in the architecture of the blood vessels in the vaginal wall, leading to decreased blood flow. This may cause the vagina to be drier than normal, and it may also change the balance between the good and bad bacteria in the vagina, which may lead to repeat genital infections or yeast infections. Women with uncontrolled diabetes may also experience recurrent yeast infections and, as a result, may experience vaginal pain and discomfort. Pain during intercourse is not infrequent. You may also notice that you are not as easily aroused or that it takes longer to become lubricated and wet. Sometimes medications that you take to control your diabetes can also influence your sexual response cycle, so it is also advisable to seek medical professional care to reassess your medications and see whether they may be contributing to your sexual dysfunction. Some women with diabetes complain of less sensitivity and less pleasure from touching or stroking during lovemaking. Other women complain of lowered libido, diminished sexual interest, and orgasmic dysfunction. Question 11. Do neuromuscular diseases like multiple sclerosis affect sexuality? Multiple sclerosis, MS, is a progressive disease of the central nervous system where gradual destruction of the myelin sheath, or coverings of the nerves, occurs. The myelin sheath surrounds and protects neurons, or brain nerve cells, and with their destruction there is a decreased ability of the nerves to carry electrical signals throughout the body, including to the genitals. Women with multiple sclerosis may need more time to get sexually aroused and may often complain of decreased arousal. Some women with this disorder may also have a variety of different patterns of orgasm. These issues are combined with ever-present fatigue from increased muscle spasms. Mobility may be difficult and paralysis may inhibit movements. Loss of bladder control may also preclude feeling at ease because of worry about incontinence or sudden loss of urine. Women may experience changes in sensation in the extremities including the hands, feet, and face, and changed sensation in the breasts and clitoris may make sexual intimacy difficult and a challenge. Often changes in bowel and bladder habits combined with depression may also affect intimate connections. Women with neuromuscular diseases typically complain of decreased vaginal lubrication and changes in vaginal muscle tone. Clitoral engorgement may also be decreased. Other issues that are related to the nervous system such as bowel problems, spasticity, muscle weakness, body or hand tremor, and changes in attention and concentration can also affect the sexual response cycle. Those with MS may also experience changes in self-esteem and may have mood swings that affect their intimate relationships. Vaginal dryness, pain, muscle spasms, and possible embarrassment over bowel and bladder incontinence can all lead to lowered libido and other sexual complaints with MS. Many medical interventions can help mitigate the problems for women with MS so that they may enjoy a fulfilling, pleasurable sexual intimate life. Consult with a sexual medicine specialist who is well versed with chronic medical disease to help you and your partner recapture a romantic sensual life. Question 12. How does cancer affect sexuality? Sexual concerns are common for women cancer survivors, and many cancer survivors face the additional issues of a changed self-image, fatigue from their cancer therapies, and fear about death and their mortality. Although not life-threatening, not having a healthy and active sex life can affect your entire relationship with your spouse or partner, as well as how you feel about yourself. The ramifications of cancer and its treatment can have a serious effect on your sexual satisfaction. Complaints of sexual dysfunction are extremely prevalent in women of all ages and with all cancer types. It is important to ask your healthcare professional for help. Some complain of having a low libido, hypoactive desire disorder, changes in orgasm, or changes in arousal. Sexual pain disorders such as dyspareunia, pain during intercourse, and vaginismus, reflexive contracture of the pelvic and vaginal muscles, are also prevalent in the female cancer population. Nearly 1/4 of those who survived leukemia or Hodgkin's disease have distressing sexual dysfunction. Sexual dysfunction is often complex and multidimensional, so an individual's treatment regimen may involve several different approaches. Healthy, satisfying sexual functioning and treatment success are affected by a variety of factors including medical illnesses, hormonal levels, relationship concerns, partner availability, underlying psychiatric disorders, general medical well-being, and cultural and religious behaviors. Question 13. What about menopause and vaginal dryness? With the end of menstrual cycles and the beginning of menopause, a wide variety of menopausal symptoms can occur. Some women complain of increased hot flashes, vaginal dryness, and mood irritability, and others complain of decreased sleep and fatigue. Mood changes and hot flashes are very common and can be contributing factors to lowered interest and sexual problems. Every woman's experience of menopause is different and unique. No two women experience the same symptoms. Race as well as culture may influence your symptomatology and subjective experience of menopause. Black, Asian, and Caucasian women may have different incidences of complaints with respect to hot flashes and vaginal dryness. The loss of estrogen can be associated with vaginal dryness and subsequent painful intercourse. The troublesome symptoms of severe and debilitating hot flashes may affect your quality of life and can impair sexual functioning. Be certain to have your hot flashes managed by a healthcare professional. Certainly, a wide variety of methods can be used to control your hot flashes, including hormones, estrogen treatment and estrogen and testosterone for refractory hot flashes. Popular types of hormone therapy include conjugated estrogens, Premarin, medroxyprogesterone acetate, Provera, and a combination of both, Prempro, that come in a variety of dosages and have minimal side effects. Another popular regime is estradiol and norethindrone acetate, Adavella. Hot flashes can also be helped by lifestyle changes, including avoidance of caffeine, alcohol, and spicy foods, and by taking some vitamin supplements. Sometimes practical suggestions can help, such as using biofeedback, changing clothing or temperature settings, avoiding cigarette smoke, and using a cooling pillow, chilo, or menopause sleepwear. Paced respirations and controlling the way you breathe are also helpful for some women. Sometimes relaxation techniques such as yoga, foot reflexology, therapeutic massage, meditation, or functionalized acupuncture programs can also be helpful with treating both menopausal and sexual complaints. There has been remarkable progress in the field of acupuncture, and it is noted to be helpful in the comprehensive management of hot flashes. Sometimes certain medications such as serotonin reuptake inhibitors, venlafaxine Effexor, paroxetine Paxil, antihypertensive medications, clonidine, methyldopa, and a few of the antiepileptics, gabapentin Neurontin, have also been shown to be effective in selected patients with hot flashes. Vaginal dryness is a serious medical issue that many women suffer with in silence. It can lead to decreased vaginal elasticity and poor pliability and stretchability. Many women with severe atrophy or dryness suffer from painful intercourse and may also suffer from frequent urinary tract infections. Vaginal dryness occurs not only in mature women but also women who breastfeed, those taking certain medications, allergy medications can be big offenders, and those who suffer from a variety of other medical conditions can all experience vaginal dryness. Vaginal dryness can lead to painful intercourse, which then leads to avoidant behavior, resulting in lowered interest. Why take part in something if it's painful and uncomfortable? There are many choices of therapy ranging from vaginal moisturizers and lubricants to minimally absorbed, local vaginal estrogen products such as creams, rings, and tablets that can help restore and revitalize the vaginal mucosal lining. These are discussed later. Non-hormonal vaginal moisturizers or vitamin E can be applied in the vaginal area and can help hydrate the vaginal tissues. Vaginal moisturizers should be used on a regular basis to help hydrate and revitalize the vaginal lining. Lubricants are designed for intercourse. Lubricants, especially those without flavors, colors, and warming additives, can and should be used liberally during intercourse. Avoid using lubricants such as petroleum jelly, Vaseline, extra virgin olive oil, and other household products because they can change the natural balance of your vaginal bacteria and in some women can lead to infections. An excellent lubricant is a water-based gel such as Slippery Stuff, which is glycerin-free. Many women find it helpful to use lubricants prior to intercourse. Some popular lubricants include Astroglide and KY Jelly, Johnson & Johnson Pharmaceuticals. Question 14. How can oral contraceptives affect sexuality? Perhaps the most controversial topic of debate that has been discussed in the field of sexual medicine is that of oral contraceptive and its influence on female sexual function. Again, the data are conflicting with respect to research and hormones. The opponents of oral contraceptive pills tout the increased levels of a protein called sex hormone binding globulin, SHBG, as a result of the oral estrogen component of the oral pills. This increase in SHBG results in a lowered free testosterone level, which many have translated into a lowered sexual interest. Although androgens including testosterone are linked to sexuality and female sexual interest, the extent to which these hormones play in female sensuality and sexuality remains to be elucidated. Interestingly, many other studies do not support the claim of changes in sexual function with the use of oral contraceptive pills. Many report neutral effects on sexual function given their chemical and hormonal makeup, like Loestrin 24, by Warner-Chicot. This pill has a shorter pill-free interval, so women who suffer from premenstrual syndrome-like symptoms have increased symptomatic relief and henceforth increased sexual interest. The same can be said for Yuz, Bayer Pharmaceuticals, since it is often prescribed for acne. This may help eliminate social isolation in the acne sufferers who may experience a boost in sexual self-esteem on the medication. There are recent concerns regarding this medication and overstated efficacy as well as potential problems with increased potassium. Donnerstein, a noted sexual medicine specialist in Australia, published research indicating that women's sexual function is more closely linked to their partner's health than to their androgen levels. Some potential benefits of birth control pills include lessened premenstrual syndrome, less bleeding, decreased anemia, and stabilization of pain from endometriosis. If these symptoms contribute to your sexual complaints, minimizing them may be associated with renewed interest in sexuality. Other studies support the notion that women who are on birth control pills have an increased sexual freedom from fear of unintended pregnancy is often liberating for the sensual woman. Before automatically jumping to conclusions and assuming that oral contraceptives are the answer to your sexual complaints, be certain to undergo a comprehensive assessment, which should include a history, physical examination, and laboratory work. Although the pills may be a minor contributor to solutions, it is wise to seek professional care from your sexual health care specialist. Oral contraception is not liked by everyone. Some women cannot tolerate it for different reasons. However, I personally think it does have many positive influences on sexuality. With birth control comes more sexual freedom. With more sexual freedom you may experience more interest in sex as well as an increase in your overall libido. The pill can be positive because it decreases cramps and blood flow, and most important it protects you from pregnancy. Not having to worry about that alone might make you more sexual. Question 15. What is vulvodynia? Vulvodynia is a condition characterized by a multitude of vaginal and vulvar complaints that can include burning, itchiness, and painful intercourse. Although there are many working diagnoses of the etiologic causes of this type of vulvar pain, none is proven to be the definitive answer. Vulvodynia is associated with sexual pain and discomfort, and many women with this condition have stopped having intercourse. Many women suffer from this condition for many years until the definitive diagnosis is made, and many go unrecognized or untreated for many years. If you have vulvar complaints, seek medical care from a specialist. Along with a complete history and physical examination, some of the following tests may be done to form a diagnosis: cotton swab test, vulvoscopy, measurement of vaginal pH secretions, and genital cultures to exclude sexually transmitted diseases like gonorrhea and chlamydia infection. A wet mount or slide preparation of the vaginal discharge will sometimes be made to see if there are other infectious processes going on as well. Vulvodynia may be associated with interstitial cystitis, so it is also important to have a complete genitourinary assessment. According to the National Vulvodynia Association, many women have very sensitive vulvar areas that can be easily irritated and lead to painful irritative symptoms including painful intercourse. The following is a list of some practical suggestions to help maintain vulvar health. Wear all white cotton underwear. Do not wear pantyhose, wear thigh-high or knee-high hose instead. Wear loose-fitting pants or skirts. Remove wet bathing suits and exercise clothing promptly. Use dermatologically approved detergents such as Purex or Clear. Limit fabric softener. Double rinse underwear and any other clothing that comes into contact with the vulva. Use soft, white, unscented toilet paper. Use lukewarm or cool sitz baths to relieve burning and irritation. Avoid getting shampoo on the vulvar area. Do not use bubble bath, feminine hygiene products, or any perfumed creams or soaps. Rinse the vulva with water after urination. Urinate before the bladder is full. Use 100% cotton menstrual pads and tampons. Be careful of contraceptive creams or spermicides. Read labels. Often many products contain irritants or allergens that can affect an already sensitive vulvar area. Thank you for listening and meet you next time.